Question 1. Operational review demonstrates a patient presenting with a witnessed ventricular fibrillation arrest. During the initial assessment, a small scar is noted over the left upper chest, and the patient is wearing a medical alert bracelet indicating a pacemaker. The paramedic is preparing to deliver a defibrillatory shock. Option A. Attempt to identify the pacemaker's location and position the defibrillation paddles at least 2 inches away from the device, using the lowest effective energy setting. Option B. Withhold defibrillation until a cardiology consult can confirm the pacemaker's compatibility with external defibrillation. Option C. Proceed with defibrillation using the standard energy setting, assuming the pacemaker will not be affected. Option D. Position the defibrillation paddles directly over the pacemaker site to ensure maximum current delivery. Correct answer is D. Position the defibrillation paddles directly over the pacemaker site to ensure maximum current delivery. Explanation. This scenario presents a professional challenge due to the potential for electromagnetic interference (EMI) to affect the function of implanted cardiac devices, specifically pacemakers and ICDs. The paramedic must balance the need for essential patient care, such as defibrillation or cardioversion, with the risk of inadvertently disabling or misinterpreting the function of these devices. Accurate recognition of the device and appropriate management are critical to patient safety and adherence to NREMT standards for paramedic practice. The correct approach prioritizes patient safety and device integrity by first attempting to identify the presence of an implanted cardiac device, and then employing management strategies that minimize the risk of EMI. This aligns with NREMT guidelines that emphasize a thorough patient assessment and the application of evidence-based interventions. Specifically, when defibrillation or cardioversion is indicated, positioning the paddles away from the implanted device and using the lowest effective energy setting are crucial steps to mitigate potential harm. This approach reflects a commitment to patient well-being and adherence to best practices in emergency cardiac care, as expected of a certified paramedic. An incorrect approach would be to proceed with defibrillation or cardioversion without considering the presence or potential impact on the implanted device. This failure to assess and account for the device represents a significant lapse in professional judgment and a potential violation of NREMT standards regarding patient safety and appropriate intervention. Another incorrect approach would be to withhold necessary life-saving therapy solely due to the presence of a pacemaker or ICD without first attempting to mitigate the risks associated with the intervention. This could lead to a delay in critical treatment, potentially resulting in adverse patient outcomes, and would also be contrary to NREMT expectations for decisive and effective patient care. Professionals should employ a decision-making framework that begins with a comprehensive patient assessment, including a search for external signs of implanted devices, e.g., scars, device identifiers. If a device is suspected or confirmed, the paramedic must then consider the urgency of the intervention versus the potential risks of EMI. This involves consulting available protocols, seeking guidance from medical direction if time permits, and applying knowledge of device function and management strategies to minimize harm while ensuring effective treatment. Question 2. The monitoring system demonstrates a patient with a respiratory rate of 8 breaths per minute and an oxygen saturation of 88% on room air. The patient is unresponsive to verbal stimuli and does not exhibit a gag reflex when the airway is gently stimulated. The paramedic has determined that a basic airway adjunct is necessary. Option A. Administer a non-rebreather mask at 15 L/min and reassess oxygen saturation. Option B. Measure the distance from the corner of the patient's mouth to the angle of the jaw and select an oropharyngeal airway OPA of that size. Option C. Attempt to insert an oropharyngeal airway OPA of a small size, as it is less likely to cause gagging. Option D. Insert a nasopharyngeal airway NPA without measuring, as NPAs are generally well tolerated in patients with an intact gag reflex. The correct answer is B. Measure the distance from the corner of the patient's mouth to the angle of the jaw and select an oropharyngeal airway OPA of that size. Explanation. This scenario presents a common challenge in emergency medicine, a patient with altered mental status and potential airway compromise. The professional challenge lies in accurately assessing the need for and selecting the appropriate basic airway adjunct while ensuring patient safety and adherence to NREMT standards. The paramedic must quickly differentiate between a patient who can maintain their own airway and one who requires assistance, considering factors like gag reflex and level of consciousness. The correct approach, which involves assessing the patient's gag reflex and selecting an OPA based on measurement, represents best professional practice because it directly aligns with NREMT guidelines for airway management. NREMT protocols emphasize a systematic approach to airway assessment and intervention, prioritizing patient safety and efficacy. The OPA is indicated for unconscious patients without a gag reflex to prevent tongue occlusion. Proper sizing is crucial to avoid gagging, vomiting, or airway trauma, as outlined in NREMT skill sheets and cognitive exam frameworks. An incorrect approach would be to blindly insert an OPA without assessing the gag reflex. This is a regulatory failure because it bypasses a critical assessment step mandated by NREMT protocols, increasing the risk of gagging, vomiting, and aspiration, which can lead to further respiratory distress or compromise. Another incorrect approach would be to select an OPA of improper size. An OPA that is too small may not effectively lift the tongue, while one that is too large can cause trauma to the epiglottis or pharynx, potentially leading to airway obstruction or injury. This is a failure to adhere to the specific procedural requirements for OPA insertion as defined by NREMT standards, which emphasize correct sizing for optimal function and patient safety. Finally, attempting to insert an OPA in a patient who clearly retains a gag reflex is an incorrect approach. This is a significant procedural error as it will likely induce gagging and vomiting, further compromising the airway and potentially leading to aspiration. NREMT guidelines clearly state that OPAs are contraindicated in patients with an intact gag reflex. Professional reasoning in such situations requires a systematic assessment of the patient's airway patency, including level of consciousness, breathing pattern, and presence of a gag reflex. Based on this assessment, the paramedic must then select the most appropriate basic airway adjunct, ensuring correct sizing and insertion technique according to NREMT standards. This decision-making process prioritizes patient safety, adherence to established protocols, and the effective management of the airway. Question 3. Quality control measures reveal a scenario where a 45-year-old male presents with sudden onset of severe respiratory distress, stridor, and cyanosis. He is conscious but unable to speak. His airway appears patent on initial inspection, but there is significant audible wheezing and accessory muscle use. The paramedic is considering immediate advanced airway intervention. Option A. Administer a racemic epinephrine nebulizer treatment to reduce potential laryngeal swelling. Option B. Attempt to visualize the airway with a laryngoscope and suction if necessary, followed by appropriate airway adjuncts or intubation if indicated by visualization. Option C. Immediately perform a blind finger sweep of the oropharynx to dislodge any potential foreign body. Option D. Proceed directly to endotracheal intubation without further visualization of the airway. The correct answer is B. Attempt to visualize the airway with a laryngoscope and suction if necessary, followed by appropriate airway adjuncts or intubation if indicated by visualization. Explanation. Scenario analysis. This scenario presents an ethical dilemma where a paramedic must balance the immediate need for airway management with the potential for patient harm due to an unknown cause of obstruction. The challenge lies in making a rapid, informed decision under pressure, considering the limited information available and the potential for exacerbating the patient's condition. The paramedic must prioritize patient safety and well-being while adhering to established protocols and ethical principles. Correct approach analysis. The correct approach involves a systematic assessment of the airway, starting with the least invasive interventions and progressing as necessary. This aligns with NREMT paramedic certification standards, which emphasize a structured approach to patient care, prioritizing direct visualization of the airway, followed by attempts at basic airway maneuvers and adjuncts, is the most appropriate course of action. This methodical process minimizes the risk of iatrogenic injury and ensures that definitive airway management is pursued only when indicated and with the appropriate tools. This approach is ethically sound as it prioritizes patient safety and adheres to the principle of do no harm. Incorrect approach is analysis. Attempting immediate intubation without a thorough assessment of the cause of obstruction is a significant regulatory and ethical failure. This bypasses crucial steps in airway management, potentially leading to esophageal intubation, trauma to the airway structures, or failure to recognize and address a treatable cause like a foreign body. This violates the NREMT emphasis on a systematic and evidence-based approach to patient care. Performing a blind finger sweep of the oropharynx without visualization is also professionally unacceptable. This action can inadvertently push a foreign body deeper into the airway, worsening the obstruction and making subsequent removal more difficult. It is a direct contravention of safe airway management practices and the ethical obligation to avoid causing harm. Administering a racemic epinephrine nebulizer treatment without first attempting to clear the airway or assess for swelling is premature and potentially ineffective. While racemic epinephrine can reduce laryngeal edema, it does not address mechanical obstruction from foreign bodies or severe trauma. This approach fails to address the most likely causes of acute airway obstruction in this scenario and delays definitive management, which is a failure in professional judgment and adherence to best practices. Professional reasoning. When faced with an acute airway obstruction, the paramedic should employ a structured decision-making process. This involves 1. Rapidly assessing the patient for signs of complete or partial airway obstruction. 2. Identifying potential causes of obstruction, foreign body, swelling, trauma, secretions. 3. Attempting basic airway maneuvers, head tilt/chin lift or jaw thrust and suctioning. 4. Utilizing airway adjuncts, OPA/NPA if appropriate. 5. If basic measures fail and signs of severe obstruction persist, proceeding to advanced airway management, e.g., direct laryngoscopy for visualization and potential foreign body removal, followed by intubation if necessary. 6. Continuously reassessing the patient's airway and ventilation status throughout the intervention. This systematic approach ensures that the most appropriate and least invasive interventions are attempted first, while also preparing for more advanced interventions when indicated, all within the framework of NREMT guidelines and ethical patient care. Question 4. Consider a scenario where a 65-year-old male is found unresponsive with shallow, infrequent respirations. He has a history of a recent tracheostomy for sleep apnea management, though it appears patent. His airway is not visibly obstructed, but he is unable to protect it. You have standard EMS equipment available, including a bag valve mask, BVM, a pocket mask with a one-way valve, and a portable suction unit. Which of the following ventilation techniques would be the most appropriate initial approach for this patient, considering NREMT paramedic certification standards? Option A. Attempt ventilation with a bag valve mask after attempting to insert an oropharyngeal airway and ventilating via the mouth. Option B. Attempt ventilation using a bag valve mask connected to supplemental oxygen, ensuring a good seal around the tracheostomy site. Option C. Perform mouth-to-mask ventilation using the pocket mask with a one-way valve, directing air into the tracheostomy. Option D. Use the bag valve mask connected to supplemental oxygen, after confirming patency of the tracheostomy and utilizing a pediatric-sized BVM adapter for a better seal. The correct answer is B. Attempt ventilation using a bag valve mask connected to supplemental oxygen, ensuring a good seal around the tracheostomy site. Explanation. This scenario presents a common but critical challenge in emergency medicine, maintaining adequate ventilation in a patient with compromised airway and respiratory function. The professional challenge lies in selecting the most appropriate ventilation technique based on the patient's condition, available equipment, and the NREMT paramedic certification standards, which emphasize patient safety and evidence-based practice. Careful judgment is required to balance speed, effectiveness, and the potential for complications. The correct approach represents best professional practice because it prioritizes a secure airway and effective ventilation delivery as outlined by NREMT guidelines and accepted medical standards. Utilizing a supraglottic airway device followed by BVM ventilation, or direct intubation if indicated and feasible, ensures a more reliable and efficient method of oxygenation and ventilation compared to less invasive techniques, especially in a patient with altered mental status and potential for aspiration. This approach minimizes the risk of gastric inflation and allows for more consistent tidal volumes, directly addressing the core need for effective gas exchange. Ventilating with a simple pocket mask or mouth-to-mouth without a barrier device is a failure to adhere to infection control protocols and significantly increases the risk of disease transmission to the rescuer, a fundamental ethical and regulatory concern for all EMS providers. Relying solely on a bag valve mask without an advanced airway in a patient with an altered mental status and potential for airway collapse is a failure to adequately secure the airway, potentially leading to ineffective ventilation, aspiration, and delayed definitive airway management, which contravenes the NREMT emphasis on prompt and effective patient care. Attempting to ventilate with a BVM directly to the stoma site without confirming patency and proper seal is a critical error, as it bypasses the natural airway and can lead to ineffective ventilation, subcutaneous emphysema, and potential injury to the tracheal stoma, failing to meet the standard of care for airway management. Professional reasoning in such situations involves a systematic assessment of the patient's airway, breathing, and circulation, ABCs. The decision-making process should prioritize securing the airway, followed by effective ventilation. This includes considering the patient's level of consciousness, the presence of any airway obstruction, and the likelihood of aspiration. The NREMT paramedic certification emphasizes the ability to perform advanced airway procedures and utilize appropriate ventilation devices. Providers should always select the method that offers the greatest assurance of adequate ventilation and oxygenation while minimizing risks, adhering to established protocols and clinical judgment. Question 5. The assessment process reveals a 65-year-old male with altered mental status following a fall. He is obtunded, moaning, and has noisy respirations with audible gurgling. His oxygen saturation is 88% on room air, and he is demonstrating paradoxical chest movement. Which of the following is the most appropriate initial airway management intervention based on NREMT paramedic certification standards? Option A. Apply positive pressure ventilation with a bag valve mask and an oropharyngeal airway. Option B. Perform endotracheal intubation to secure a definitive airway. Option C. Insert a nasopharyngeal airway and administer high-flow oxygen. Option D. Attempt a needle decompression of the chest. The correct answer is B. Perform endotracheal intubation to secure a definitive airway. Explanation. This scenario presents a common challenge in airway management, where a patient's clinical presentation necessitates rapid and effective intervention, but the initial assessment may not immediately point to a single definitive cause. The professional challenge lies in accurately identifying the underlying issue and selecting the most appropriate airway adjunct or definitive airway strategy that aligns with NREMT paramedic scope of practice and current evidence-based guidelines, while also considering patient safety and minimizing potential complications. The correct approach represents best professional practice because it prioritizes a systematic assessment of the airway, recognizing signs of compromise, and selecting an intervention that directly addresses the identified problem according to NREMT guidelines. This involves considering the patient's oxygenation status, ventilation effectiveness, and the presence of any obstructions or anatomical difficulties. Utilizing a supraglottic airway or proceeding to endotracheal intubation, when indicated by NREMT protocols and the patient's condition, are established methods for securing a definitive airway when less invasive measures are insufficient. This approach is supported by NREMT standards, which emphasize the paramedic's role in managing compromised airways and the use of approved advanced airway techniques. An incorrect approach, such as solely relying on a basic airway adjunct like a nasopharyngeal airway, when signs of significant airway compromise or inadequate ventilation are present, fails to meet the patient's needs and violates the principle of providing definitive care when necessary. This could lead to prolonged hypoxia and further patient deterioration, which is contrary to NREMT standards of care. Another incorrect approach, such as attempting a surgical airway without clear indications or proper training and equipment, as outlined by NREMT protocols, introduces unnecessary risk and is outside the typical paramedic scope of practice in most pre-hospital settings unless specific local protocols and advanced training are in place. This bypasses established, safer methods for airway management. Professional decision-making in such situations requires a thorough understanding of airway anatomy and physiology, proficiency in various airway management techniques, and the ability to rapidly assess and reassess the patient's condition. Paramedics must adhere to their NREMT certification and local protocols, utilizing a stepwise approach that begins with basic interventions and progresses to advanced techniques as indicated by the patient's response and the severity of their condition. This includes considering the potential for aspiration, the effectiveness of ventilation, and the need for definitive airway control. Question 6. Upon reviewing a patient receiving mechanical ventilation in the pre-hospital setting, you observe a sudden decrease in SpO2 and increased work of breathing despite the current ventilator settings. The patient is agitated and appears to be fighting the ventilator. What is the most appropriate initial course of action? Option A. Immediately increase the respiratory rate and tidal volume to improve oxygenation. Option B. Discontinue mechanical ventilation and initiate bag valve mask ventilation. Option C. Assess the patient for signs of bronchospasm or pneumothorax, reassess airway security and ventilator tubing for kinks or disconnections, and consider a brief period of manual ventilation with 100% oxygen to assess patient response. Option D. Administer a bolus of sedative medication to calm the patient and improve ventilator synchrony. Correct answer is C. Assess the patient for signs of bronchospasm or pneumothorax, reassess airway security and ventilator tubing for kinks or disconnections, and consider a brief period of manual ventilation with 100% oxygen to assess patient response. Explanation. This scenario presents a common yet critical challenge in paramedic practice, managing a patient requiring mechanical ventilation with rapidly deteriorating respiratory status. The professional challenge lies in the need for immediate, accurate assessment and intervention within the constraints of pre-hospital emergency care, while adhering strictly to NREMT guidelines and established best practices for mechanical ventilation. The paramedic must balance the urgency of the situation with the systematic application of knowledge to ensure patient safety and optimal outcomes. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based assessment and intervention strategy. This involves confirming the patient's airway security, reassessing ventilator parameters against the patient's current physiological state, and considering potential underlying causes for the deterioration. This aligns with NREMT emphasis on critical thinking, patient assessment, and the application of advanced life support skills within the scope of paramedic practice. The focus on identifying and addressing the root cause of the respiratory distress, rather than simply adjusting settings in isolation, is paramount. An incorrect approach that involves solely increasing the respiratory rate without a thorough reassessment of other ventilatory parameters or the patient's overall condition fails to address potential underlying issues such as bronchospasm, pneumothorax, or circuit malfunction. This could lead to barotrauma or volatrauma, exacerbating the patient's condition. Ethically, this represents a failure to provide appropriate care and a potential violation of the duty to act. Another incorrect approach, such as discontinuing mechanical ventilation without a clear indication or alternative means of supporting respiration, would be a direct contravention of established protocols for patients requiring mechanical support and would likely result in immediate cardiorespiratory arrest. This demonstrates a lack of understanding of the patient's dependency on the ventilator and a failure to maintain the airway and breathing. A third incorrect approach, focusing solely on sedation without addressing the ventilatory mechanics, ignores the primary problem of inadequate gas exchange. While sedation may be necessary for patient comfort and synchrony with the ventilator, it does not resolve the underlying respiratory issue and could mask signs of worsening hypoxia or hypercapnia. This represents a failure to prioritize interventions based on physiological need. Professional reasoning in such situations requires a structured approach. First, ensure the airway is secure and the patient is adequately oxygenated. Second, systematically assess the patient and the ventilator, considering all potential causes of deterioration. Third, intervene based on the most likely cause, prioritizing interventions that directly address gas exchange and patient comfort. Finally, continuously reassess the patient's response to interventions and be prepared to escalate care or modify the treatment plan as needed, all within the NREMT scope of practice. Question 7. Strategic planning requires a paramedic to anticipate potential patient needs and select appropriate interventions. Given a patient presenting with mild shortness of breath and an initial SpO2 of 93% on room air, which of the following sequences of oxygen therapy management best reflects a systematic and evidence-based approach according to NREMT guidelines? Option A. Administer oxygen via nasal cannula at 6L/min and document the patient's subjective improvement without further SpO2 monitoring. Option B. Immediately apply a non-rebreather mask at 15L/min to ensure adequate oxygenation from the outset. Option C. Administer oxygen via a simple face mask at 6-8L/min and continue this until the patient's SpO2 reaches 100%. Option D. Administer oxygen via nasal cannula at 2-4L/min. Reassess SpO2 and respiratory status, and if SpO2 remains below 94% or respiratory distress increases, escalate to a non-rebreather mask at 10-15 L/min. The correct answer is D. Administer oxygen via nasal cannula at 2-4 L/min. Reassess SpO2 and respiratory status, and if SpO2 remains below 94% or respiratory distress increases, escalate to a non-rebreather mask at 10-15 L/min. Explanation: this scenario presents a common challenge in emergency medical services, managing a patient with a potentially compromised respiratory status, where the initial assessment may not fully capture the severity of the underlying issue. The professional challenge lies in accurately assessing the patient's oxygenation needs and selecting the most appropriate delivery device and flow rate to optimize oxygenation without causing harm, all while adhering to NREMT guidelines and best practices. Careful judgment is required to balance the need for adequate oxygenation with the risks of oxygen toxicity or hyperventilation. The correct approach represents best professional practice because it prioritizes a systematic assessment of the patient's respiratory status, including vital signs and clinical presentation, to guide the selection of oxygen therapy. Utilizing a nasal cannula initially for a patient with mild hypoxia or as a step-down therapy is appropriate, but the subsequent escalation to a non-rebreather mask based on worsening oxygen saturation and respiratory distress demonstrates a dynamic and responsive approach. This aligns with NREMT guidelines that emphasize titrating oxygen therapy based on patient response and objective data, SpO2. The administration of oxygen at a high flow rate, 10-15 L/min, via a non-rebreather mask is indicated for moderate to severe hypoxia, aiming to achieve an SpO2 of 94-99%. An incorrect approach would involve prematurely administering high-flow oxygen via a non-rebreather mask without a clear indication of significant hypoxia or respiratory distress. This could lead to unnecessary oxygen administration, potentially masking underlying issues or contributing to oxygen toxicity in the long term, though acute toxicity is less of a concern in the pre-hospital setting. Another incorrect approach would be to rely solely on subjective patient complaints without objective SpO2 monitoring, as this can lead to under- or overtreatment. Failing to adjust oxygen therapy based on the patient's response and SpO2 readings is a critical failure in patient care and deviates from NREMT standards, which mandate continuous reassessment and adjustment of treatment. The professional decision-making process for similar situations should involve a thorough primary and secondary assessment, focusing on airway, breathing, and circulation. Objective data, such as SpO2 readings, respiratory rate, and work of breathing, should guide the selection and titration of oxygen therapy. Understanding the indications and contraindications for various oxygen delivery devices is crucial. Professionals should always consider the potential risks and benefits of oxygen administration and be prepared to adjust their treatment plan based on the patient's evolving condition. Question 8. Examination of the data shows a patient with a recently secured endotracheal tube displaying a capnography waveform that is significantly reduced in height and has a gradual return to baseline, with an ECHO2 reading of 22 mmHg. The patient is receiving bag valve mask ventilation. Option A. Increase the rate of bag valve mask ventilation, assuming the ECHO2 reading indicates hypoventilation. Option B. Focus solely on the numerical ECHO2 value of 22 mmHg and continue bag valve mask ventilation without further investigation. Option C. Assess the integrity of the advanced airway and the effectiveness of ventilation by evaluating the capnography waveform and numerical ECHO2 in conjunction with the patient's clinical status. Option D. Discontinue capnography monitoring, as the numerical ECHO2 reading is within an acceptable range for a hypotensive patient. Correct answer is C. Assess the integrity of the advanced airway and the effectiveness of ventilation by evaluating the capnography waveform and numerical ECHO2 in conjunction with the patient's clinical status. Explanation: this scenario presents a common yet critical challenge in advanced airway management, interpreting capnography data to ensure adequate ventilation and oxygenation in a patient with a secured advanced airway. The professional challenge lies in the subtle but significant deviations from expected capnography readings, which can indicate a range of issues from dislodgement to inadequate perfusion. Misinterpretation can lead to delayed or incorrect interventions, potentially causing patient harm. The correct approach represents best professional practice by directly correlating the observed capnography waveform and numerical values with the patient's physiological status and the integrity of the advanced airway. NREMT paramedic certification emphasizes the ability to apply critical thinking to real-time patient data, adhering to established protocols for airway management and ventilation. This includes recognizing abnormal findings and initiating appropriate corrective actions as outlined in NREMT guidelines and standard paramedic practice. The ethical imperative is to provide the highest standard of care, which necessitates accurate assessment and timely intervention based on objective data like capnography. An incorrect approach that focuses solely on the numerical value of end-tidal carbon dioxide ECO2 without considering the waveform morphology is a significant regulatory and ethical failure. NREMT guidelines stress the importance of the entire capnographic display, not just a single number. The waveform provides crucial information about the patient's breathing pattern, the presence of rebreathing, and the effectiveness of ventilation. Ignoring the waveform can lead to misdiagnoses of critical issues such as bronchospasm, airway obstruction, or equipment malfunction. Another incorrect approach that prioritizes subjective patient assessment over objective capnography data also represents a failure. While clinical signs are important, capnography provides a continuous, objective measure of ventilation and perfusion. Relying solely on the absence of visible chest rise or breath sounds, for example, while disregarding a normal ECO2 reading, could lead to overlooking a critical underlying problem that capnography would otherwise reveal. This deviates from the NREMT emphasis on data-driven decision-making. Furthermore, an approach that assumes the advanced airway is functioning correctly solely because it was recently placed, without continuous objective verification via capnography, is a dangerous oversight. NREMT standards require ongoing assessment and validation of interventions. Capnography is the gold standard for confirming and monitoring the placement and function of an advanced airway. Failure to utilize this tool for continuous validation is a breach of professional responsibility and potentially violates NREMT guidelines regarding airway management. The professional reasoning framework for this situation involves a systematic approach. 1. Observe and interpret the complete capnography data, waveform morphology and numerical ECO2. 2. Correlate capnography findings with the patient's clinical presentation, vital signs, lung sounds, chest rise, patient appearance. 3. Consider the context of the patient's condition and the recent interventions, e.g., advanced airway placement. 4. Formulate a differential diagnosis for any observed abnormalities. 5. Implement appropriate interventions based on the most likely diagnosis and established protocols. 6. Continuously reassess the patient and the capnography data to evaluate the effectiveness of interventions. Question 9. Performance analysis shows that paramedics often face challenges in differentiating between upper and lower airway obstructions in patients presenting with respiratory distress. Considering the anatomy and physiology of the lower airway, including the trachea, bronchi, bronchioles, and alveoli, which of the following assessment findings would most strongly suggest a primary lower airway issue requiring specific interventions? Option A. History of sudden onset of choking, followed by difficulty breathing and unilateral diminished breath sounds. Option B. Visible suprasternal retractions and accessory muscle use with clear breath sounds on auscultation. Option C. A high-pitched inspiratory stridor and hoarseness, with minimal air movement noted on auscultation. Option D. The presence of diffuse wheezing bilaterally on auscultation, accompanied by increased work of breathing and a productive cough. The correct answer is D. The presence of diffuse wheezing bilaterally on auscultation, accompanied by increased work of breathing and a productive cough. Explanation. Scenario analysis. This scenario presents a common clinical challenge where a patient exhibits signs of respiratory distress, necessitating a rapid and accurate assessment of the underlying cause. The difficulty lies in differentiating between upper and lower airway obstruction, as the interventions differ significantly. Misinterpreting the location of the obstruction can lead to delayed or inappropriate treatment, potentially worsening the patient's condition and violating the NREMT emphasis on evidence-based practice and patient safety. Correct approach analysis. The correct approach focuses on identifying signs and symptoms indicative of lower airway compromise, specifically involving the trachea, bronchi, bronchioles, and alveoli. This includes assessing for wheezing, rhonchi, decreased breath sounds, and the presence of sputum or secretions. Understanding the physiology of these structures, such as the role of smooth muscle in bronchoconstriction and the function of alveoli in gas exchange, guides the paramedic to consider conditions like asthma, COPD exacerbations, or pneumonia. This aligns with NREMT standards that require paramedics to apply knowledge of anatomy and physiology to diagnose and manage patient conditions effectively, ensuring appropriate interventions are initiated promptly. Incorrect approaches analysis. One incorrect approach might involve focusing solely on stridor or hoarseness, which are classic signs of upper airway obstruction. While these signs require immediate attention, their presence suggests a different anatomical location and pathophysiology than lower airway issues. Relying on these signs alone without a comprehensive assessment of lower airway function would lead to a misdiagnosis and potentially ineffective treatment, failing to meet NREMT standards for thorough patient assessment. Another incorrect approach could be to immediately administer a bronchodilator without first confirming the presence of lower airway involvement through auscultation and symptom assessment. While bronchodilators are crucial for certain lower airway conditions, their indiscriminate use can be detrimental if the obstruction is not bronchospasm-related or if it masks a more critical issue. This deviates from the NREMT requirement for a systematic and evidence-based approach to patient care. A third incorrect approach might be to assume a foreign body aspiration solely based on sudden onset of respiratory distress, without considering other common lower airway pathologies. While foreign body aspiration can affect the lower airways, it typically presents with a history of choking or gagging. Failing to consider the broader differential diagnosis for lower airway compromise, as expected by NREMT standards, represents a failure in clinical reasoning. Professional reasoning. Paramedics must employ a systematic approach to patient assessment, beginning with a primary survey to identify life threats, and then proceeding to a focused secondary assessment. For respiratory distress, this includes a detailed history, vital signs, and a thorough physical examination, with particular attention to the respiratory system. Auscultation of breath sounds is paramount for differentiating upper from lower airway issues. Understanding the pathophysiology of common lower airway conditions allows for the formulation of a differential diagnosis and the selection of appropriate interventions, adhering to NREMT certification requirements for competent patient care. Question 10. System analysis indicates a 68-year-old male patient is experiencing shortness of breath. He states he feels okay and not that bad, but your assessment reveals a respiratory rate of 28 breaths per minute, shallow depth, and audible expiratory wheezing in all lung fields. He is alert and oriented but appears anxious. He declines any immediate respiratory interventions, stating he just needs to catch his breath. What is the most appropriate immediate course of action? Option A. Reassure the patient that he will feel better soon and continue to monitor his respiratory status without intervention. Option B. Document the patient's subjective report and refuse to administer any treatment until he explicitly requests it. Option C. Immediately initiate positive pressure ventilation with a bag valve mask due to the abnormal lung sounds and elevated respiratory rate. Option D. Administer supplemental oxygen via nasal cannula and prepare for nebulized bronchodilator therapy, explaining the rationale to the patient. The correct answer is D. Administer supplemental oxygen via nasal cannula and prepare for nebulized bronchodilator therapy, explaining the rationale to the patient. Explanation. This scenario presents a professional challenge due to the conflict between a patient's stated preference and the paramedic's clinical judgment based on objective assessment findings. The paramedic must balance patient autonomy with the ethical and legal obligation to provide appropriate medical care, adhering to the NREMT scope of practice and established protocols. The core of the dilemma lies in determining the appropriate level of respiratory intervention when a patient, despite subjective comfort, exhibits objective signs of respiratory distress. The correct approach prioritizes a thorough and objective respiratory assessment, including auscultation of lung sounds, and then acts in accordance with established protocols and clinical judgment to address any identified abnormalities. This aligns with the NREMT emphasis on evidence-based practice and the paramedic's responsibility to provide the highest level of care within their certification. By objectively assessing the patient's respiratory status, the paramedic can identify potential deterioration that the patient may not be fully aware of or able to articulate. Acting on these objective findings, even if they contradict the patient's stated comfort, is a demonstration of professional responsibility and adherence to the paramedic's duty of care. This approach upholds the principle of beneficence, acting in the patient's best interest, while also respecting patient autonomy to the extent that it does not compromise safety. An incorrect approach that dismisses the objective findings based solely on the patient's subjective report fails to uphold the paramedic's duty of care. This could be considered a breach of professional responsibility, as it neglects critical clinical data that may indicate a worsening condition. Ethically, it prioritizes patient preference over patient well-being when there is a clear discrepancy, potentially violating the principle of beneficence. Legally, it could be viewed as a failure to provide appropriate medical care as dictated by the patient's condition, potentially leading to adverse outcomes. Another incorrect approach that involves immediate, aggressive intervention without a comprehensive assessment, despite the patient's stated comfort, might overstep the paramedic's scope of practice or fail to adequately consider the patient's perspective. While acting to prevent potential harm is important, a balanced approach that includes thorough assessment and consideration of the patient's input is crucial. This could be seen as a failure to respect patient autonomy and could lead to unnecessary interventions or patient distress. The professional decision-making process in such situations requires a systematic approach. First, conduct a complete and objective respiratory assessment, including auscultation, rate, rhythm, depth, and effort. Second, compare these objective findings with the patient's subjective report. Third, consult local protocols and consider the patient's overall clinical picture. Fourth, communicate clearly with the patient, explaining the assessment findings and the rationale for any proposed interventions. Finally, act in a manner that best ensures patient safety and well-being, while respecting patient autonomy as much as possible within the bounds of safe medical practice. Question 11. Analysis of a patient's arterial blood gas results reveals a pH of 7.25, a PaCO2 of 60 mmHg, and a HCO3 of 24 mx/L. Considering the NREMT paramedic certification exam's regulatory framework, which interpretation best guides immediate paramedic management? Option A. The findings suggest a primary metabolic acidosis, requiring administration of bicarbonate. Option B. The findings point to a primary respiratory alkalosis, indicating hyperventilation. Option C. The findings are indicative of a compensated metabolic alkalosis, requiring fluid resuscitation. Option D. The findings indicate a primary respiratory acidosis, necessitating interventions to improve ventilation. The correct answer is D. The findings indicate a primary respiratory acidosis, necessitating interventions to improve ventilation. Explanation. This scenario presents a professionally challenging situation due to the critical nature of acid-base derangements and their direct impact on patient physiology and potential for rapid deterioration. As a paramedic, interpreting these values requires a nuanced understanding beyond simple memorization, demanding the ability to correlate them with the patient's clinical presentation and guide appropriate interventions within the NREMT scope of practice. Careful judgment is required to differentiate between primary respiratory and metabolic causes and to recognize the implications for ventilation and oxygenation strategies. The correct approach represents best professional practice by directly linking the laboratory findings to the underlying pathophysiology and the paramedic's role in patient management. Specifically, recognizing a low pH with a high PaCO2 and a normal or compensatory HCO3 strongly suggests a primary respiratory acidosis. This understanding aligns with NREMT guidelines that emphasize the paramedic's responsibility to assess and manage respiratory distress, which includes understanding how ventilation directly influences CO2 levels and, consequently, acid-base balance. The ethical imperative is to provide timely and appropriate care based on the best available evidence and understanding of physiological principles, which in this case points towards interventions aimed at improving ventilation. An incorrect approach that focuses solely on the HCO3 value without considering the PaCO2 and pH would be a significant regulatory and ethical failure. This would demonstrate a lack of understanding of the dynamic interplay between these parameters and could lead to misdiagnosis and inappropriate treatment. For instance, if a paramedic were to solely focus on a low HCO3 and assume a metabolic acidosis without considering the respiratory component, they might overlook the primary need for ventilatory support, violating the NREMT emphasis on comprehensive patient assessment and management. Another incorrect approach, such as attributing the findings to a purely metabolic cause without considering the respiratory contribution, would also be a failure. This demonstrates a superficial understanding of acid-base balance and a disregard for the interconnectedness of respiratory and metabolic systems, potentially leading to delayed or incorrect interventions, which is ethically unacceptable and contrary to professional standards. The professional decision-making process for similar situations should involve a systematic approach. 1. Assess the patient's overall clinical presentation, vital signs, level of consciousness, signs of respiratory distress, and any relevant medical history. 2. Interpret the provided laboratory values in conjunction with the clinical picture. 3. Correlate the pH, PaCO2, and HCO3 to identify the primary acid-base disturbance, respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis, or mixed disorder. 4. Determine the likely underlying cause of the disturbance based on the patient's presentation and the acid-base pattern. 5. Formulate a treatment plan that addresses the identified cause and aims to stabilize the patient, prioritizing interventions within the NREMT scope of practice, such as airway management and ventilation. 6. Continuously reassess the patient's response to interventions and adjust the plan as necessary. Question 12. The evaluation methodology shows that a patient presents with significant hypoxemia despite a normal respiratory rate and adequate tidal volume. Arterial blood gas analysis reveals a low partial pressure of oxygen, PaO2, and a normal partial pressure of carbon dioxide, PaCO2. Based on these findings and an understanding of respiratory physiology, which of the following is the most likely primary physiological problem? Option A, increased metabolic demand for oxygen. Option B, increased dead space ventilation. Option C, inadequate minute ventilation. Option D, impaired diffusion of gases across the alveolar capillary membrane. The correct answer is D, impaired diffusion of gases across the alveolar capillary membrane. Explanation. The evaluation methodology shows that assessing a paramedic's understanding of respiratory physiology requires them to apply theoretical knowledge to clinical scenarios. This scenario is professionally challenging because it requires the paramedic to differentiate between two distinct physiological processes that can present with similar outward signs, necessitating a deep understanding of the underlying mechanisms of gas exchange and cellular respiration. Accurate assessment is critical for appropriate treatment selection and patient outcomes. The correct approach represents best professional practice because it directly addresses the core physiological deficit described in the scenario. By focusing on the impaired diffusion of oxygen across the alveolar capillary membrane, the paramedic is identifying the root cause of hypoxemia. This aligns with NREMT standards that emphasize evidence-based practice and understanding the pathophysiology of respiratory distress to guide interventions. Correctly identifying the primary issue allows for targeted management, such as administering supplemental oxygen to improve the partial pressure gradient for diffusion, or considering interventions that reduce alveolar capillary membrane thickening if indicated. An incorrect approach that focuses solely on tachypnea without considering the underlying cause fails to address the fundamental problem of inadequate gas exchange. While tachypnea is a compensatory mechanism, it does not explain the hypoxemia itself. This approach risks misdiagnosis and delayed or inappropriate treatment, potentially leading to worsening hypoxia. Ethically, this represents a failure to provide the standard of care expected of a certified paramedic. Another incorrect approach that prioritizes increasing minute ventilation through hyperventilation without addressing the diffusion barrier is also flawed. While increasing ventilation can improve CO2 removal, it may not effectively increase oxygenation if the diffusion of oxygen into the blood is severely compromised. This could lead to a false sense of improvement while the underlying hypoxemia persists, violating the ethical obligation to provide effective care. A further incorrect approach that solely considers increased metabolic demand without investigating the primary respiratory impairment overlooks a critical aspect of the scenario. While increased metabolic demand can exacerbate hypoxemia, it is unlikely to be the primary cause of the observed gas exchange abnormalities in this context. Focusing on this without addressing the diffusion issue would be a deviation from best practice and could lead to ineffective interventions. The professional decision-making process for similar situations involves a systematic approach, 1. Assess the patient's presentation, noting signs and symptoms. 2. Formulate a differential diagnosis based on the pathophysiology of respiratory distress. 3. Prioritize interventions based on the most likely and life-threatening causes. 4. Continuously reassess the patient's response to interventions. 5. Consult with medical direction when necessary. This scenario demands a nuanced understanding of gas exchange principles, moving beyond superficial signs to identify the underlying physiological derangement. Question 13. Benchmark analysis indicates that paramedics frequently encounter situations where pulse oximetry readings may not accurately reflect a patient's oxygenation status. Considering the limitations of pulse oximetry, which of the following represents the most appropriate initial management strategy for a patient presenting with shortness of breath and a reported SpO2 of 88% on scene, but who is alert, oriented, and breathing comfortably with minimal accessory muscle use? Option A. Assess for factors that might be affecting pulse oximetry accuracy, such as poor peripheral perfusion or patient movement, while simultaneously evaluating the patient's work of breathing, skin color, and mental status to determine the need for supplemental oxygen. Option B. Administer high-flow oxygen via non-rebreather mask and initiate transport immediately, as the SpO2 reading indicates significant hypoxia. Option C. Focus solely on the SpO2 reading of 88% and administer supplemental oxygen via nasal cannula at 2L/min, as this is the standard protocol for any SpO2 below 90%. Option D. Reapply the pulse oximeter to the other ear, and if the reading remains 88%, assume the reading is accurate and proceed with advanced airway management. The correct answer is B. Administer high-flow oxygen via non-rebreather mask and initiate transport immediately, as the SpO2 reading indicates significant hypoxia. Explanation: this scenario presents a common challenge in emergency medical services, interpreting a vital sign that may not accurately reflect the patient's true physiological state. Pulse oximetry, while a valuable tool, has known limitations that can lead to misdiagnosis and inappropriate treatment if not understood. The professional challenge lies in integrating the SpO2 reading with other clinical data and patient presentation to form a comprehensive assessment. The correct approach prioritizes a holistic patient assessment, recognizing that a single SpO2 reading is not definitive. Best professional practice, as guided by NREMT standards and general paramedic principles, dictates that the paramedic must consider factors that can affect pulse oximetry accuracy, such as poor perfusion, ambient light, nail polish, and patient movement. It also emphasizes the importance of correlating the SpO2 reading with other signs of respiratory distress or hypoxia, such as respiratory rate, work of breathing, skin color, mental status, and the patient's chief complaint. This approach aligns with the NREMT emphasis on critical thinking and the application of knowledge in real-world clinical situations, ensuring patient safety and appropriate care. An incorrect approach that relies solely on the numerical SpO2 value without considering these limitations is professionally unacceptable. For instance, assuming hypoxia based solely on a low SpO2 reading without further assessment could lead to unnecessary interventions or delayed treatment for the actual underlying cause. This failure to perform a thorough clinical assessment violates the NREMT expectation of a competent paramedic who can critically evaluate all available data. Another incorrect approach might be to dismiss a normal SpO2 reading in a patient with clear signs of respiratory distress, potentially delaying life-saving interventions. This demonstrates a lack of understanding of the limitations of the device and a failure to prioritize the patient's observable clinical condition. The professional decision-making process for similar situations involves a systematic approach. 1. Recognize the patient's chief complaint and initial presentation. 2. Obtain vital signs including SpO2. 3. Critically evaluate the SpO2 reading in the context of the patient's overall condition. Consider potential factors that could be affecting the accuracy of the pulse oximetry reading. 5. Correlate the SpO2 reading with other objective and subjective findings, e.g., respiratory rate, breath sounds, skin color, mental status, patient report of dyspnea. 6. Formulate a differential diagnosis and treatment plan based on the comprehensive assessment, not just a single vital sign. 7. Reassess the patient frequently and adjust the treatment plan as needed. Question 14. Research into pediatric airway management techniques has highlighted the unique anatomical considerations in young patients. A 3-year-old child presents with stridor, retractions, and mild cyanosis following a fall. The child is conscious but appears distressed and is breathing spontaneously at a rate of 40 breaths per minute. Which of the following interventions, when applied according to NREMT guidelines for pediatric care, best addresses the immediate airway concern? Option A. Insertion of a properly sized nasopharyngeal airway and ventilation with a bag valve mask device, delivering appropriate tidal volumes to achieve visible chest rise. Option B. Administration of a bronchodilator via nebulizer and observation for spontaneous improvement in airway patency. Option C. Blind insertion of a supraglottic airway device without prior airway adjuncts. Option D. Insertion of an oropharyngeal airway and immediate initiation of bag valve mask ventilation with high-flow oxygen. Correct answer is A. Insertion of a properly sized nasopharyngeal airway and ventilation with a bag valve mask device, delivering appropriate tidal volumes to achieve visible chest rise. Explanation. This scenario presents a professionally challenging situation due to the critical nature of pediatric airway management and the potential for rapid deterioration in a young patient. The anatomical differences in pediatric airways, such as a smaller pharynx, larger tongue relative to oral cavity, and a more anterior larynx, necessitate specialized techniques to avoid airway obstruction and trauma. The challenge lies in accurately assessing the patient's needs and selecting the most appropriate airway adjunct and ventilation strategy that minimizes risk while maximizing effectiveness, all within the NREMT scope of practice and guidelines. The correct approach represents best professional practice because it prioritizes patient safety and evidence-based interventions, utilizing a properly sized nasopharyngeal airway, NPA, in a conscious or semi-conscious pediatric patient with signs of airway compromise is a recognized and recommended intervention by pediatric resuscitation guidelines, including those referenced by the NREMT. NPAs are designed to bypass the tongue and maintain an open airway without stimulating a gag reflex as intensely as an oropharyngeal airway, OPA, might in a semi-conscious patient. Proper sizing is crucial to avoid airway obstruction or injury. Ventilation with a bag valve mask, BVM device, with appropriate tidal volume and rate, is the standard for providing positive pressure ventilation when spontaneous breathing is inadequate. An incorrect approach would involve selecting an airway adjunct that is contraindicated or poses a higher risk in this specific pediatric presentation. For instance, attempting to insert an OPA in a semi-conscious child could precipitate laryngospasm, further compromising the airway. Similarly, selecting an NPA that is too large could cause nasal trauma or obstruction, while one that is too small would be ineffective. Failure to adequately assess the need for airway support or to use appropriate ventilation techniques, such as delivering excessive tidal volumes which can lead to gastric insufflation and subsequent complications, would also be a failure to adhere to best practices and NREMT guidelines. These failures represent a deviation from the standard of care, potentially violating ethical principles of beneficence and non-maleficence, and demonstrating a lack of competence in pediatric airway management, as expected of a certified paramedic. The professional decision-making process for similar situations should involve a systematic assessment of the pediatric patient's airway, breathing, and circulation, ABCs. This includes evaluating the level of consciousness, presence of spontaneous respiration, signs of distress, e.g., retractions, nasal flaring, stridor, and oxygenation status. Based on this assessment, the paramedic must determine if airway adjuncts are necessary, and if so, select the most appropriate device considering the patient's age, anatomy, and level of consciousness. Ventilation techniques should be tailored to the pediatric patient, focusing on appropriate tidal volumes and rates to achieve effective chest rise without hyperinflation. Continuous reassessment of the patient's response to interventions is paramount. Question 15. The evaluation methodology shows a 62-year-old male complaining of sudden onset chest pain radiating to his left arm, accompanied by diaphoresis and a feeling of impending doom. His electrocardiogram reveals ST segment elevation in leads Roman 2, Roman 3, and a VF. Based on your understanding of cardiac anatomy and physiology, which coronary artery is most likely compromised? And what is the primary electrical consequence of this compromise? Option A. Left anterior descending artery, impaired conduction through the sinoatrial node. Option B. Right coronary artery, impaired conduction through the atrioventricular node. Option C. Left main coronary artery, impaired conduction through the Purkinje fibers. Option D. Circumflex artery, impaired conduction through the bundle of His. The correct answer is B. Right coronary artery, impaired conduction through the atrioventricular node. Explanation. The evaluation methodology shows a scenario where a paramedic must interpret complex cardiac physiology in a patient presenting with signs of myocardial ischemia. This is professionally challenging because subtle differences in the presentation can indicate critical differences in the underlying pathology and require precise application of knowledge to ensure appropriate and timely intervention. The paramedic must not only recall anatomical structures and their functions, but also understand how disruptions to these systems manifest clinically. The correct approach represents best professional practice because it directly links the patient's clinical presentation to the underlying cardiac anatomy and physiology, specifically focusing on the coronary arteries and the conduction system. This aligns with NREMT paramedic certification standards, which emphasize a thorough understanding of the cardiovascular system structure and function to guide patient assessment and management. By identifying the likely affected coronary artery and its implications for the conduction system, the paramedic can prioritize interventions that address the root cause of the patient's condition, such as reperfusion therapy and management of potential arrhythmias. This demonstrates a commitment to evidence-based practice and patient safety, core tenets of paramedic certification. An incorrect approach that focuses solely on a generalized symptom without considering the specific anatomical structures involved fails to meet the depth of understanding required for paramedic certification. This represents a regulatory failure by not adhering to the NREMT emphasis on detailed physiological knowledge. Another incorrect approach that misidentifies the primary electrical pathway's role in the patient's presentation demonstrates a critical knowledge gap in cardiac conduction, leading to potentially inappropriate treatment and a failure to meet professional standards of care. A third incorrect approach that overlooks the role of coronary artery perfusion in maintaining myocardial function would result in a delayed or incorrect diagnosis, potentially leading to irreversible myocardial damage and a violation of the ethical obligation to provide the highest standard of care. Professionals should use a systematic decision-making framework that begins with a comprehensive assessment of the patient's signs and symptoms. This assessment should then be correlated with knowledge of cardiac anatomy and physiology, specifically considering the location of potential ischemia or infarction, the affected coronary arteries, and the impact on the cardiac conduction system. This allows for the formulation of a differential diagnosis and the selection of the most appropriate diagnostic and therapeutic interventions, always referencing established protocols and guidelines consistent with NREMT standards. Question 16. Stakeholder feedback indicates a need to reinforce best practices in managing patients with unstable tachyarrhythmias. You are presented with a 68-year-old male experiencing sudden onset of severe shortness of breath and altered mental status. On cardiac monitoring, he is found to be in a regular, wide complex tachycardia at a rate of 180 beats per minute with a palpable pulse. His blood pressure is 80/50 mmHg, and he appears diaphoretic. Which of the following actions is the most appropriate initial intervention? Option A. Administer unsynchronized defibrillation at 200 joules biphasic. Option B. Obtain a 12-lead ECG and administer amiodarone 150 mg Roman 4 push. Option C. Prepare for and perform synchronized cardioversion at 100 joules biphasic. Option D. Initiate chest compressions and prepare for unsynchronized defibrillation. The correct answer is A. Administer unsynchronized defibrillation at 200 joules biphasic. Explanation. Scenario analysis. This scenario presents a common challenge in emergency medical services where a patient exhibits a rhythm amenable to synchronized cardioversion, but the patient's clinical status is rapidly deteriorating. The professional challenge lies in balancing the need for immediate intervention to restore a stable rhythm with the potential risks associated with cardioversion, such as inducing a more dangerous arrhythmia or causing patient discomfort and injury if not performed correctly. The urgency of the situation demands swift, yet precise, decision-making based on established protocols and clinical judgment. Correct approach analysis. The correct approach involves recognizing the specific rhythm, confirming its hemodynamic instability, and preparing for synchronized cardioversion. This aligns with NREMT Paramedic certification guidelines, which emphasize the appropriate use of defibrillation and cardioversion based on patient presentation and rhythm analysis. Synchronizing the electrical impulse to the R wave is critical to avoid delivering energy during the vulnerable T wave, which could precipitate ventricular fibrillation. The decision to cardiovert is based on the presence of a pulse and signs of hemodynamic compromise, indicating that the current rhythm is directly contributing to the patient's instability. This represents best professional practice as it directly addresses the underlying cause of the patient's deterioration in a controlled and evidence-based manner. Incorrect approaches analysis. Administering unsynchronized defibrillation to a patient with a pulse, even if unstable, is a significant regulatory and ethical failure. NREMT guidelines clearly differentiate between defibrillation, unsynchronized, for pulseless rhythms, and synchronized cardioversion for rhythms with a pulse that are causing instability. Unsynchronized shocks in the presence of a pulse can lead to the induction of ventricular fibrillation, a life-threatening complication, and is therefore a direct violation of safe patient care protocols. Delaying intervention to await further diagnostic information, such as a 12-lead ECG, when the patient is hemodynamically unstable and exhibiting a rhythm amenable to cardioversion, represents a failure to act in a timely manner. While diagnostic information is valuable, the immediate threat to the patient's life from the unstable rhythm takes precedence. Prolonged delay can lead to irreversible organ damage or cardiac arrest, violating the ethical principle of beneficence and the regulatory requirement to provide timely and appropriate care. Administering antiarrhythmic medications without first attempting synchronized cardioversion, when cardioversion is indicated and feasible, is also a professional failure. While medications may be part of the overall treatment plan, they are often not as immediately effective as electrical intervention for unstable tachyarrhythmias. Relying solely on medications in this acute, unstable situation could delay definitive treatment and worsen the patient's condition, contravening best practices for managing hemodynamically unstable rhythms. Professional reasoning. Professionals should employ a systematic approach. 1. Assess the patient's airway, breathing, and circulation, ABCs. 2. Analyze the cardiac rhythm using the monitor. 3. Determine if the patient has a pulse. 4. If a pulse is present, assess for signs of hemodynamic instability, e.g., altered mental status, hypotension, chest pain, signs of shock. 5. If the rhythm is unstable and the patient is unstable, consider synchronized cardioversion. 6. If the rhythm is pulseless, consider unsynchronized defibrillation. 7. Follow local protocols and NREMT guidelines for energy levels and sequence of interventions. 8. Continuously reassess the patient's response to treatment. Question 17. Which approach would be most appropriate for a 62-year-old male presenting with substernal chest pain radiating to his left arm, diaphoresis, and a history of hypertension? Option A. Administer pain medication for the chest pain and monitor vital signs until symptoms resolve. Option B. Administer oxygen, aspirin, and nitroglycerin as indicated, obtain a 12-lead ECG, and transport rapidly to the nearest cardiac-capable facility. Option C. Obtain a detailed medical history and perform a thorough physical examination before initiating any interventions. Option D. Provide oxygen and transport to the nearest emergency department for further evaluation and diagnostic testing. Correct answer is B. Administer oxygen, aspirin, and nitroglycerin as indicated, obtain a 12-lead ECG, and transport rapidly to the nearest cardiac-capable facility. Explanation. This scenario presents a common yet critical challenge in emergency medical services. Differentiating between various acute coronary syndromes acts based on limited initial information and the patient's presentation. The professional challenge lies in the rapid assessment and accurate interpretation of subtle clinical cues to guide immediate interventions and transport decisions, all while adhering to NREMT standards for paramedic practice. The patient's history of hypertension and current complaint of substernal chest pain radiating to the left arm, coupled with diaphoresis, strongly suggests an acute cardiac event. The paramedic must consider the potential for myocardial infarction, MI, unstable angina, or other serious cardiac pathology. The correct approach prioritizes rapid, focused assessment, immediate administration of appropriate interventions based on suspected ACS, and prompt transport to a facility capable of definitive cardiac care. This aligns with NREMT guidelines that emphasize the paramedic's role in recognizing and managing life-threatening conditions, including ACS. The administration of oxygen, aspirin, nitroglycerin, if appropriate and not contraindicated, and obtaining a 12-lead electrocardiogram, ECG, are cornerstone interventions for suspected ACS. The prompt transport is critical because time is muscle in the context of MI. Delays can lead to irreversible myocardial damage and poorer outcomes. This approach reflects best professional practice by adhering to established protocols for ACS management, prioritizing patient safety, and ensuring timely access to advanced medical care. Incorrect approaches fail to adequately address the urgency and potential severity of the patient's condition. Delaying definitive interventions such as aspirin or nitroglycerin, or waiting for further diagnostic information before initiating treatment, constitutes a failure to act within the expected timeframe for ACS management. This delay can lead to progression of myocardial damage and increased morbidity. Furthermore, a failure to obtain a 12-lead ECG promptly is a significant deviation from standard ACS protocols, as it is the primary diagnostic tool for identifying ST elevation, myocardial infarction, STEMI, and guiding reperfusion therapy. Transporting the patient to a non-cardiac capable facility without first stabilizing or definitively diagnosing the condition would also be a critical error, potentially leading to delays in receiving life-saving interventions. These failures represent regulatory and ethical breaches by not providing the standard of care expected for a patient with suspected ACS. The professional decision-making process in such a situation involves a systematic approach: rapid scene assessment, immediate patient assessment (APDET), focused history and physical examination, consideration of differential diagnoses, with ACS at the forefront given the symptoms, initiation of appropriate interventions based on protocols and clinical judgment, and timely transport to the most appropriate facility. This process is guided by NREMT competency statements and the paramedic's understanding of pathophysiology and pharmacology. Question 18. The review process indicates a 68-year-old male presenting with severe respiratory distress, altered mental status, and a GCS of 8. His airway is patent but shallow with audible stridor. He has a history of severe obstructive sleep apnea and a short, thick neck. The paramedic has successfully applied a bag valve mask, BVM, with supplemental oxygen, but ventilation remains difficult and ineffective. Considering NREMT guidelines for advanced airway management, which of the following represents the most appropriate initial advanced airway intervention? Option A. Perform a needle cricothyrotomy due to the presence of stridor, indicating potential upper airway obstruction. Option B. Administer a racemic epinephrine nebulizer treatment to reduce airway edema and improve airflow before considering advanced airway placement. Option C. Insert a supraglottic airway device, such as a King LT or laryngeal mask airway, LMA, recognizing the patient's anatomical challenges and the need for rapid airway control. Option D. Attempt endotracheal intubation using a videolaryngoscope, focusing on direct visualization of the vocal cords. Correct answer is D. Attempt endotracheal intubation using a videolaryngoscope, focusing on direct visualization of the vocal cords. Explanation: this scenario presents a professionally challenging situation due to the dynamic nature of patient presentation and the critical need for timely and appropriate airway management. The paramedic must rapidly assess the patient's condition, identify the most suitable advanced airway adjunct based on NREMT guidelines, and execute the chosen technique effectively while anticipating potential complications. The challenge lies in balancing the urgency of securing an airway with the need for a precise and evidence-based approach, adhering strictly to NREMT standards for paramedic practice. The correct approach represents best professional practice because it prioritizes patient safety and optimal oxygenation/ventilation through the application of advanced airway management techniques as outlined by NREMT protocols, specifically selecting an appropriate supraglottic airway or endotracheal tube based on patient anatomy, clinical presentation, and the paramedic skill set, and then performing the procedure with attention to detail and confirmation of placement, directly aligns with NREMT emphasis on evidence-based practice and patient care standards. This ensures the patient receives the most effective intervention to prevent hypoxia and improve outcomes, reflecting the paramedic's commitment to the highest level of care within their scope of practice. An incorrect approach, such as attempting an advanced airway without clear indication or in a contraindicated situation, represents a significant regulatory and ethical failure. This could lead to patient harm, including airway trauma, esophageal intubation, or delayed definitive airway management, all of which violate the NREMT core principles of patient safety and competent practice. Proceeding with a technique for which the paramedic lacks proficiency or failing to adequately confirm airway placement are also critical failures, demonstrating a disregard for established protocols and potentially jeopardizing the patient's life. Such actions fall outside the scope of NREMT certification and ethical paramedic conduct. Professional decision-making in similar situations requires a systematic approach. First, a rapid but thorough assessment of the patient's airway, breathing, and circulation is paramount. Second, the paramedic must consider the indications and contraindications for various advanced airway adjuncts as defined by NREMT guidelines. Third, the paramedic's own skill proficiency with specific devices must be a factor in the decision. Fourth, the chosen technique should be executed with meticulous attention to detail, followed by immediate and ongoing confirmation of correct placement and effectiveness. Finally, continuous reassessment of the patient's status and the airway's effectiveness is crucial. Question 19. The analysis reveals a 65-year-old male who has sustained severe facial trauma following a motor vehicle accident. He is conscious but obtunded, with significant facial swelling and bleeding obscuring his oral and nasal passages. Despite attempts with a bag valve mask, effective ventilation is not being achieved, and the patient is becoming increasingly cyanotic. Paramedic has already attempted insertion of a supraglottic airway without success due to the facial trauma. Based on the NREMT paramedic certification exam's regulatory framework, what is the most appropriate next step in managing this patient's airway? Option A, reattempt bag valve mask ventilation with a different airway adjunct. Option B, administer a rapid sequence intubation. Option C, initiate chest compressions due to suspected cardiac arrest. Option D, proceed with cricothyrotomy. The correct answer is D. Proceed with cricothyrotomy. Explanation. This scenario presents a professionally challenging situation due to the critical nature of airway management and the potential for rapid patient deterioration. The paramedic must make a swift, informed decision regarding the appropriateness of a cricothyrotomy, balancing the urgency of the situation against the potential risks and contraindications. Careful judgment is required to avoid unnecessary invasive procedures while ensuring definitive airway management when indicated. The correct approach represents best professional practice because it aligns with the National Registry of Emergency Medical Technicians, NREMT. Paramedic certification exams emphasis on evidence-based practice and patient safety. It prioritizes a thorough assessment of the patient's condition to determine if the indications for cricothyrotomy are met, specifically the inability to secure the airway by less invasive means, and the presence of a cannot intubate, cannot ventilate scenario. This adheres to established protocols and guidelines for emergency airway management, ensuring that the procedure is performed only when it is the most appropriate and life-saving intervention. An incorrect approach involving immediate cricothyrotomy without a comprehensive assessment of less invasive airway options would represent a significant regulatory and ethical failure. It bypasses established protocols that mandate attempting simpler airway maneuvers first, potentially leading to unnecessary patient harm and complications associated with an invasive procedure. Performing cricothyrotomy when a patient can be adequately ventilated with a bag valve mask or supraglottic airway is a violation of the principle of do no harm and deviates from accepted standards of care as outlined by NREMT guidelines. Another incorrect approach, delaying the decision to perform a cricothyrotomy despite clear indications of airway compromise and inability to ventilate, would also be a critical failure. This inaction could lead to irreversible hypoxic brain injury or death, violating the paramedic's ethical and legal duty to provide timely and appropriate care. Such a delay would demonstrate a failure to recognize and respond to a life-threatening emergency, contravening the core tenets of emergency medical services. The professional reasoning process for similar situations should involve a structured approach to airway management. This includes 1. Assessing the patient for signs of airway obstruction or compromise. 2. Attempting less invasive airway interventions e.g., bag valve mask ventilation, supraglottic airway insertion, and assessing their effectiveness. 3. If less invasive methods fail and the patient cannot be ventilated, then considering definitive surgical airway interventions like cricothyrotomy, ensuring all indications are met and contraindications are absent. This systematic approach, guided by NREMT standards, ensures patient safety and optimal outcomes. Question 20. Risk assessment procedures indicate a 55-year-old male found unresponsive with snoring respirations. He has significant facial trauma, including suspected nasal fractures and lacerations around the mouth. His Glasgow Coma Scale score is 8. What is the most appropriate initial airway management intervention? Option A. Insert an oropharyngeal airway, OPA, using proper technique. Option B. Insert a nasopharyngeal airway, NPA, after lubricating the tip. Option C. Administer positive pressure ventilation with a bag valve mask, BVM, without any adjunct. Option D. Continue to monitor the patient's respiratory status without intervention. Correct answer is A. Insert an oropharyngeal airway, OPA, using proper technique. Explanation. Scenario analysis. This scenario presents a common challenge in prehospital care where a patient exhibits signs of airway compromise requiring intervention. The difficulty lies in accurately assessing the patient's condition and selecting the most appropriate airway adjunct based on anatomical considerations and potential contraindications, all while adhering to NREMT scope of practice and established protocols. The presence of facial trauma adds complexity, potentially obscuring landmarks and increasing the risk of complications with certain airway adjuncts. Correct approach analysis. The correct approach involves a thorough assessment of the patient's airway, breathing, and circulation. Given the patient's decreased level of consciousness and snoring respiration, an oropharyngeal airway, OPA, is indicated to maintain an open airway by preventing the tongue from obstructing the pharynx. The OPA is chosen over a nasopharyngeal airway, NPA, due to the facial trauma, which could increase the risk of epistaxis or further injury with an NPA. Proper insertion technique, including measuring the OPA from the corner of the mouth to the angle of the jaw and inserting it with the tip pointing towards the pharynx, then rotating it 180 degrees as it passes the teeth, is crucial for effective placement and to avoid damaging oral structures. This aligns with NREMT guidelines for basic airway management. Incorrect approach is analysis. Selecting an NPA without considering the facial trauma is an incorrect approach. While an NPA can be effective in maintaining an open airway, its insertion through the nasal passage can exacerbate bleeding or cause further damage in the presence of facial fractures or significant nasal trauma. This could lead to complications such as intracranial placement or severe epistaxis, which are not in line with patient safety principles and NREMT protocols for airway management in trauma. Attempting to ventilate the patient with a bag valve mask, BVM, without first addressing the airway obstruction is also an incorrect approach. While BVM ventilation is a critical skill, it is less effective if the airway is already compromised by a blocked pharynx. The snoring respirations indicate a partial obstruction that needs to be relieved before positive pressure ventilation can be optimally delivered. This delays definitive airway management and may lead to inadequate oxygenation. Choosing to do nothing and continuing to monitor the patient without intervention is incorrect. The patient's decreased level of consciousness and snoring respirations are clear indicators of impending airway failure. Delaying intervention in such a situation violates the principle of prompt and appropriate patient care and can lead to hypoxia, brain injury, or cardiac arrest, which are preventable outcomes. Professional reasoning. Professionals should approach this situation by prioritizing the ABCs: airway, breathing, circulation. A systematic assessment of the airway is paramount. If an obstruction is identified, the least invasive yet most effective intervention should be chosen. In this case, the snoring respirations and decreased consciousness point to a need for an OPA. The presence of facial trauma necessitates careful consideration of contraindications for NPAs. If the OPA is ineffective or the patient's condition deteriorates, further advanced airway interventions would be considered according to NREMT protocols and local medical direction. Documentation of the assessment findings, interventions, and patient response is also a critical component of professional practice.